Okay, so thank you again for joining us for this panel discussion today. As many of you must have seen the agenda and puzzled over the broadness of the topic to see that what does it actually mean. It was actually very intentional and deliberate from our side to keep the topic as broad as possible so that the discussion can be a lot more free flowing. And I definitely wanted the panelists to give them the choice to choose whatever, because they've all been working in the health space for many years. And again, health is extremely broad, but it was really important that we sort of get all of these perspectives in a much more free-flowing manner. Having said that, because this event does focus on evidence, there are certain things that we would really like to get most from this discussion. And as you all also think about questions that you might want to ask from our panelists, I would really like to emphasize that the focus, to whatever extent possible, should be on the use of evidence. Now let me say a little bit more about what I mean by evidence. So on the first hand, evidence is something which could be directly about the impact of doing X number of X activities, of doing launching certain policies and programs. What does it do to our outcomes, which could be represented by a Y. And there we do have a lot of evidence from around the world on certain things which are related to human behaviors, which are related to behavioral economics, which are related to uptake of health services, which are related to how do you motivate and incentivize the healthcare workers. That could then inform the design of different policies and programs. So that's one layer or one level of evidence which is extremely important to keep in mind. But the second and the most important one, which I would really like us to kind of talk about, is related to implementation. So even if our design is absolutely right, or even if our planning is very good, most often than not, things do sort of, go haywire, or we are not able to achieve the outcomes we want to at the ground level. There is the last mile problem for a range of health services, despite huge investments from the side of the central government, from the side of different state governments. We are still not being able to make major changes in the outcomes, in certain very basic outcomes of health, such as nutrition, such as infectious diseases, and so on and so forth. So it would be really good to also, in this panel discussion, really focus on how data and how administrative data or how monitoring data can really help play a very important role to help us course correct, to help us rethink how we are sort of implementing these policies and programs, so that the end users or the recipients are able to actually access a good, high quality healthcare. Now, just to say a little bit about how I'm planning to structure the panel. So first, I would like to give 5 minutes to each of the panelists to talk about a specific topic that they have worked on or that they would like to sort of discuss. After which we will have a moderated discussion, which I will facilitate. And then towards the last 20 minutes, we'll open it up for Q&A from all of you. Okay, so let's start. So should we start with Ms. Jayanti Ravi?
So good morning, everybody. So I'm going to talk about one particular evidence-based intervention in Gujarat that we've implemented, and also refer to certain other initiatives. So a quick overview, we're going to talk about our approach that we're currently following. This is a little state specific. I don't know how many of you have visited Gujarat. How many of you have been there? Okay, that's a very big number, a good number. The rest of you also, we'd like to invite you. And then, so the main center of this is going to be what we see at the center there, the TECO Plus. TECO is an acronym for Technology Enabled Community Health Operations. It was just a pleasant coincidence that Sridhar, who is also on this panel. So this has been implemented. It started way back in the year 2009, in a way, in Gujarat. But in the year 2013, there's a very good NGO based in Jhagadia. It's called Seva Rural. And so this was actually started by them at that time with active support of the government partnership. And this pilot, we had an RCT done by ICMR and WHO. And actually, this is one of those few interventions which started in a very small way. Not only did it show very promising results, the RCT showed it, and we were wondering whether it would be effective at all, whether it would be acceptable to the people here, the ASHAs and so on, and the end users who are actually, they're the ones who are seeking or who we want to seek our health services. but more important, and then also came the questions of cost effectiveness, how frugal is it, and so on. We'll talk about that as well. But we also thought it, I say we, but I joined the government in this position in 2017. But I think I still feel that we all own it from the time it began then. So I think the one common factor was to keep this track of research or strand of research on concurrently all through this. So there have been several publications, several studies that have been held. And I was very happy that in the year 2017, with the Honorable Prime Minister from his hometown of Vadnagar in Gujarat, we were actually able to scale this up for the entire state. So this is one small example of something which started as a tiny pilot, proof of concept. There was evidence, and based on all the facts, we were actually able to scale it up. And other than that, today, just giving you again, coming back to the overview, I'll talk a little bit about what is again something very, very dear to us now, this early childhood 1,000 days approach. We're really pushing this in a very big way from conception up to 2 years. These 1,000 days is when as many as 100 billion neural networks get formed in the brain of a baby. So if you really want to look at cognitive development and not just external development alone, the two are important. That's important. And SATCOM is, we use this a studio and we use a satellite-based communication. We have got receiving centers in all our primary health centers. We'll talk a little bit about the Saptadhara and midwifery. But now this is again a quick overview about where do we stand vis-a-vis India. The presentation is available for you as well. So right from the TB notification rate, we're doing much better than the average for India, to the maternal mortality rate too. So we've crossed what the SDGs want us to, but we do want to bring it down to as low as we can, and so on. Now this is a comprehensive approach that we're now trying to adopt through TECO. So it's not just RCH or reproductive child health centric. It's talking of other areas. As you know, it's talking of communicable diseases. We're also giving, because there's an epidemiological shift, there's a lot of NCDs. Now that's a major, if you look at the DALIs and so on. So we're giving a lot of focus on this. Mental health again. So we have this very, very good partnership with NIMHANS, the National Institute of Mental Health and Neurosciences, and we're trying a whole host of things for this area. And of course, in addition to this, nutrition, which cuts across all segments, not just the young, adolescent and so on, but for the elderly as well. Now, so we come straight away to TECO. So this was, as I said, this is the acronym stands for Technology-Enabled Community Health Operations. The idea was if you can have real-time data entry. Now, data entry is actually not correctly capturing it. It's not really about data entry, but this was meant to be a job aid for every worker at the grassroots, the ASHA. And we were very sensitive, I hope, the entire team from the beginning, to try and be very cautious that it didn't become a job ad. Because a lot of times technology adds to your work rather than actually aiding you. So a lot of care was taken, and these were originally, it started with the ASHAs. And they had this small feature, a very ordinary cell phone way back then. And at the time of service delivery, so when she woke up in the morning, she would have a scheduler. It would actually tell her what are the tasks she needs to do. And when she went to the place, and all she did is all these decision trees, as many as 40 to 60 of them have evolved over time. So it keeps leading her through different questions, and the answers, all she has to do is fill in a yes or a no or something. And the response that the app gives to her ranges from immediately summoning the 108 ambulance, if the answers to it, if the triaging that is done of the the beneficiary or the person that she's watching, to the other extreme of doing nothing, but probably just giving them some videos, some counseling and so on of a very ordinary nature. So it ranged from that to that, and all this was happening at the time and at the place of service delivery. And we're very happy, as I said, that we were also able to scale it up. Now so this is a little journey. So 2013, the research proposal development was implemented. It began, and then we had this pilot project in 6 primary health centers of Bharuch district. And then 2016, the RCT, it began in 22 of the PHCs, because by then it had been scaled up with the baseline. I mean, there were 6, and then the others, which were the control group, and the other, which were the non-intervention group. Then 2018, we had the end line evaluation that happened in March. And then 2018 onwards, while the decision, we had the initial results by 17 end, so October, we took a policy decision to scale it up. And now, as I speak, we've captured almost 95% of the entire population of Gujarat. The family health survey has been done, which is huge. We're talking of, those of you who are familiar with crores and lakhs, we're talking about nearly 6.5 crore population data has been captured. And as I was just sharing a little before earlier in the day with Sridhar as well, a lot of times we confuse technology being the silver bullet, but here the basic issue is about change management. I think more than technology, of course, is very important, extremely important, process re-engineering, all of it. But here you were dealing with bringing about an acceptance in this whole community. So right now it's being implemented across our 9,000 odd female health workers, or the ANMs, auxiliary nurse midwives as we call them. So the results, this shows the RCT results on TACO Plus. This was done, as I mentioned, with WHO. You may like to take a look at it later as well in detail if you want. But it very clearly showed, if you see mothers visited 3 times by the ASHA. In the intervention group, this was now 53.7 as against 39.2 earlier. And if you see similarly for each of these parameters, there's a huge improvement. There's a modified, and so if we look at the modified ASHA-centric composite coverage index, which was again, we tried to get that for all of this, a more aggregated parameter. There too, there's a good improvement, significant improvement. And so the implementation of this whole, from the innovation up to implementation, we followed this research methodology which was used when it started from initially a very small, tiny set of 45 villages. And now it is spread across all the 18,000 villages of Gujarat. So earlier we started with something called like rose cultivation. We took up one small group, and now it's like rice cultivation with, we're trying to take care that the sensitivity, the attention to detail is exactly of the kind that we were able to give there. So phase 1 was a pilot, and here these words are very important. It was first to assess the acceptability and feasibility. In that too, these 45 villages in Jhagadia were tribal villages. We first of all wanted to check. We weren't sure if this technology aid would really be accepted and whether it would be feasible. But after that, the phase 2, the questions changed from it was an overwhelming articulation that yes, this is happening, but then it moved on to cost effectiveness studies. And now this may seem very high by Indian standards, but this has been shown that it's highly cost effective. So per life year saved, it's about $74 is what it is the implication, and similarly $5,057 per death averted, which I'm told compares very well with the compared to international data that we have, and it's had several peer-reviewed publications on it. And now, again, as we're doing this entire statewide scale-up, we're doing a effectiveness of this along with the Indian Institute of Public Health in collaboration with the Department of Health Research, that is ICMR, and Seva Rural as well. So this again talks about what has happened, something of particular use. As I said, it's being now used by more than 10,000 female health workers. It includes urban areas, rural areas, tribal, all of them. And it has extended beyond the RMNCH plus A areas to cover all of these as well. This is very interesting. What we've also done is we've embedded each of these triaging or areas, verticals, with videos relevant to it. So we've got a whole bunch of videos in it. So the ASHA can actually show, now that we have smartphones, originally it came with a small simple feature phone way back then when we started it, but now we have these smartphones. So we've got all these videos there, and it's very easy for the ASHA to speak to the mother or the family members and also show relevant videos here. And it has actually moved to a paperless reporting system. So now our entire HMIS is happening using this. So there is no data entry happening at any other point except the place where the service is actually offered by the person who gives the service, real time, real place. So these are some other things. So with that, TACO is over. I'll quickly, given that I think my 5 minutes are almost done, but this was again an initiative that Gujarat started, obstetric ICUs. And we would be very happy because I think we see the overwhelming value in this evidence-based when we really have an informed policy decision which is taken based on these. So this is again something that started in Gujarat and now it has become a very accepted national intervention which has been adopted across the country. But we'd be very happy to see if some of these can be again tried out. These are some of our experiences that we found of the obstetric ICU in Surat, what was before and after. But it didn't have the rigor of an RCT, but nevertheless, this is data that we've captured. It's also been actually documented in this book, coffee table book called Proven Paths. Incidentally, all the three of them. TECO is also mentioned in it, and so is the obstetric ICU. Mentioned in it, and of course now this is again something that we're all very excited about, the first 1,000 days, and we've put together these modules given that there's a continuum of care right from the mother or the household, community, ASHA, A&M, all the way to the SNCU. We've got relevant modules which are connected with this 1,000-day idea, and we're working in partnership with an NGO called Samhita, based out of Bombay, but then with a whole lot of other stakeholders. We're all working together to make this happen. Satellite communication. So this is, we have a studio in Gandhinagar from where we're able to, every Saturday, we have a program where we reach out to all our ashas across the state. And this is a very powerful way. So we can also have some of these initiatives now checked. Saptadhara, we're also trying to use cultural forms because we feel that a major hurdle here is behavior change communication. A lot of it is about that. So we're using puppets, music, and all of this in a very big way without having to get people from outside, but actually leveraging on these abilities in our own functionaries. We have nearly 100,000 functionaries working with us if we include the ashas and so on. So we find that there's a lot of openness and a lot of keenness, enthusiasm to adopt all these different modes of communicating for behavior change. And so that has also been adopted by us. And midwifery, again, it's one of the first urban health model for the whole of India, first time happening in a structured way. So the inverted triangle that we currently see, where in urban areas, almost everybody is rushing and crowding in the tertiary care centers. So we want to see this triangle getting inverted and have people actually access the primary health centers and then the secondary and so on. And this is being done with the help of the midwives. And we're trying to see first co-locate them in our hospitals. So we have midwifery-led labor rooms initially even in the medical colleges, and then slowly crowd it out. And once people have enough confidence and faith, move them out.
I have to say a very exciting presentation, because this is sort of the holy grail for us, where you have a program sort of at a proof of concept level which was implemented by an NGO in a small part of Gujarat, and then there is a rigorous randomized evaluation done by sort of third-party organizations to look into its, the impact that this is happening, and then you have the government sort of scaling it up and taking it to the next level. I mean, the numbers that you have shown are absolutely fantastic, and it's actually trying to solve a very, very fundamental problem from both perspectives of not having data on children, on a lot of these health outcomes in real time, because the HIMS data, I mean, sorry to say, but for many, many states that the quality of the data is still very questionable, given that it's always been sort of paper based, and to the other extent of having the ASHA workers be very overburdened by this thing of doing these paper-based entries. So I think it's really solving for a really fundamental problem, but the way it has been done is something that we always aspire to do here at JPAL. So thank you so much, ma'am, for this wonderful presentation. Now I would like to have Mr. Sridhar, if you could talk a little bit, because I know that you're also going to talk a little bit about the focus on health workers. So it will be great to hear your perspective.
CARE is has been working for different, in the health arena at least for the last 3 to 4 decades in India. And for more than 2 decades, specifically in large programs to help particularly the ICDS and health frontline workers perform better and make the programs more effective. From 1996 to 2010, there was a large program called the Integrated Nutrition Health Project that was running across 8 states, and from 2010 to now, we are, among other things, one very large program which is working right across Bihar through a technical support unit approach, which is trying to improve both facility-based as well as outreach worker-based services across, and simultaneously help the government strengthen systems. So it's a deeply embedded technical support program that's been going on for 9 years now. Throughout all this, our emphasis has been on impact, essentially asking essentially that there are such large investments that have already been made at such large scale. How do you render them effective? What does it take within government programs, with all the constraints that we know that exist, to actually translate this into translate these investments into results? So in the process, we have looked at everything from purpose to design, strategy, operational details, content, measurements, evaluations, end to end. And from the many things that we have learned, I'll just like to, in the time available, just focus on a few things related to behavior change, because that seems to be quite one of those things that has kind of got waylaid by many other apparently more important objectives, particularly strengthening of medical services ever since NRHM came has come to the fore. While ASHAs did come in most states, the ASHAs, from being a social, basically an activist or somebody who represents the community to draw down services from the government, that has largely transformed to becoming somebody who mobilizes people, essentially brings up the numbers that are required for immunization programs, family planning, and institutional delivery, and so on. So there has been a dilution of the role of ASHAs. ASHA was expected to actually be the health department's front to the answer to Anganwadi workers, because for whatever reasons they could not work together. And we ended up actually creating one more worker who does a lot of the numbers game in most states, and some states are doing a little better. But in all of this, one thing that has really fallen through the cracks is the focus on behavior change. And behavior change, we are here talking about, even if the limited spectrum of family planning, maternal health, neonatal health, child health, even within that, there are at least 4 or 5 core areas where we know that even today we can actually impact mortality and malnutrition through change in the practice of caring and feeding to mothers and children at home. And that's, science tells us that, evidence tells us that. When we get down to actually making it happen, it's been a very, very slow process. Just a couple of examples. If you look at what is happening to, let us say, complementary feeding, which is the core of trying to address stunting today, malnutrition, and all that goes with it. Even in the best of states, the NFHS 4 coverage was around 29% of minimum dietary diversity. I mean, we are talking about states like Tamil Nadu, Kerala, and so on. So there is a certain some aspects of our health and nutrition programs that have simply gone into the background. We have not been able to get our act together on that at all in almost any state. The second example would be, for example, the newborn babies. Are we getting the best? For example, in the Gadchiroli study, it was very clearly shown that a lot can be achieved through frontline workers in terms of reductions in neonatal mortality. We converted that into the HBNC program, the home-based newborn care program. It needed a certain level of focus, but because of that lack of sharp focus that was there in the original program, we have nowhere close to similar results are we seeing in the large, when it got translated. So these are the kinds of limitations, that, I mean, the failures that have been there on the behavior change front. And looking at, what we've been doing is trying to, first of all, introduce different interventions for how translating the science, the messages into what simple doable actions the frontline workers can actually perform, number one. Number two, setting up delivery mechanisms through which on a periodic basis, on a monthly or even more frequent basis, somebody or the other is asking the frontline workers questions about, okay, is this really happening? Third, measuring indicators that are just not available in the otherwise in the programs. The one example that I gave you was the feeding practices. Feeding practices, practically no information is available from within the HMIS. Similarly, the home-based newborn care that I talked about, we talk about it, but do we have any reliable measures on whether women are being actually visited at the right time with the right message? That kind of information is not available. So that's one lack of data. The second is that the programs largely rely on two primary strategies: train and pay. It's as if you pick up a bunch of workers, give them adequate training, and give them some kind, either monthly payments or payments on a piece basis for each task that they perform. Somehow that will translate into actions on the ground which will bring about some transformations. Most of these conditionalities we are not able to replicate in large programs within the government, and that's one of the design problems, and we need to find ways to at least overcome that. Even if you're not able to provide that charismatic leadership, can we at least have good supportive supervision, the availability of data, and so on and so forth. We are actually losing time. See, in 2003, the first of the Lancet series came up, which basically said, these are the set of evidence-based interventions. If you get them to the people, you'll be able to reduce mortality substantially. It's been 16 years since then. Most of those interventions actually haven't reached nowhere as effectively, and we have not seen in most places the bending of the curve on mortality and malnutrition that we should have seen by now. That series and several subsequent series also lamented the fact that we know the what of it, but we still don't know the how of it. How do we actually go about changing it? In the meanwhile, mortality rates have fallen substantially. The scope, the window that's available for behavior change programs to actually change mortality in children is quite limited already, and we'll need to start doing our economics on that. Is it really worth pushing frontline workers to do that part of it? Malnutrition probably remains something like fertility, that is finding unmet need, and that's one of the other things. It's very easy to have large programs that say push this method, but very, very few programs are really looking at, so who requires it? And how do you know that you're actually, offering the choice that that is supposed to be offered, and then letting people to choose? So that kind of nuancing we have not been able to get done inside. In Bihar, we tried many of these things for at a level of investment that was just enough to cause change in behaviors and practices by about 15 to 20% over about 18 months, over a population of about 28 million, about 8 districts. And that was through monthly facilitations of sub-center level meetings of ASHAs, Anganwadi workers, and ANMs, just to say, just to review, plan, and provide some incremental content over several months. This came up, this actually gave us results. The government was very keen to scale it up immediately. It got scaled up. But when it actually got scaled up, the level of attention that was required from within programs to run this on a day-to-day basis, that they could not muster. And this is not an isolated story. I think we've been basically looking at this for quite some time. Is it possible for the leadership within the government to give, say, half an hour every day at the directorate level to behavior change issues? When I asked this question to both ICDS and health directorates in the state government in Bihar, there was silence in the room. It is too much for them to believe that behavior change is something that can merit that kind of attention. So that level of attention is not being given. We do not have decentralized data coming in. What is required was supervisory data that could be acted upon locally, and we could, where local leaders could take action to see what more could happen. That kind of local decentralized leadership using data to bring about local change has not been possible in most places, and this is one of the reasons why behavior change has not really succeeded. Thanks. I'll stop here.
Okay, thank you so much. This was again, I think, a very good perspective and also a very sobering sort of take on where we need to really start. When we start thinking about scale, then there are certain problems which are sort of inbuilt in no matter how great a program is, how rigorous the evidence could be at a proof of concept stage, but just by virtue of trying to take it to multiple people, there will be breakdowns. And I think what for me really stood out from your discussion, Mr. Sridhar, was the fact that you're also helping us to take a step back and look at the genesis of a lot of these cadre of health workers, like what was the purpose when they sort of came into being. So the fact that ASHAs have activists as a part of that acronym is something that we forget, and we might think of them as any other health worker, or like the Anganwadi worker, or maybe even ANMs. So I think that that's something that really stood out. But then the questions remain that what type of infrastructure, what type of things do we need to think about from the very beginning, the moment you think about scale? So, I mean, I'm saying something very controversial, but even thinking about the idea of doing something as proof of concept and then transferring that knowledge to scale, is it something that even we can think about to work? I mean, we do have an example from the beginning where it did work, and maybe because it was a technological intervention that might sort of mean that it could, kind of generate the data in the real time and help us see. But even in JPAL, for example, there is a movement now where we are doing at-scale evaluations. So we are doing RCTs not for some, which are also really important to test innovations. It's really important to do proof of concepts. But for certain things, we are doing them as a part and as being embedded within the government departments and at scale. And then seeing what are the impacts then. So those were some really good ideas. I'm not going to open it up for any clarificatory questions because we are running short on time, and I would now like Sapna to give us, for 5 minutes, something that she wants to talk about.
Is this okay, the microphone? Thank you so much. I'm going to shift gears a bit and talk about health insurance and talk about the evidence landscape and basically tell you a story about the evidence landscape around health insurance. And this story also began at a SEVA, but a different SEVA in Gujarat, the Self-Employed Women's Association, where I spent many years previous to the POP Council. So at SEVA, we ran one of the first community-based health insurance schemes in the country before the advent of RSBY, called Vimo Seva. And when I was running the program, this was about 2006, in a very routine administrative analysis of monitoring data. And this is something that's fascinating. Despite the words health insurance, most health insurance schemes don't analyze claims utilization patterns from a health perspective, i.e. what are the conditions for which claims are being submitted. So in a routine analysis, we found that hysterectomy, the removal of the uterus, was the #1 claim amongst rural women at the average age of 36. And at that point, I frankly fell off my chair because at the age of 36, if women were getting their uteri and usually ovaries removed, menopause is induced, and this means a lot for lifetime risk of NCDs in particular, osteoporosis and cardiovascular disease. So women are being placed at risk for a whole host of other health conditions. So we started to find out why. And this was the evidence story because monitoring data at that point wasn't enough. So we conducted one of the first prevalence studies, just comparing insured and uninsured women initially in Gujarat, in rural and urban areas. But again, that wasn't enough, and extended that to an epidemiologic cohort study to understand the incidence of hysterectomy amongst both insured and uninsured women, and also ran a trial led by Seva's health workers to see if health education, of explaining to women, having them understand what hysterectomy was, would be sufficient or effective in reducing at least claims for hysterectomy. It's not surprising that we didn't find evidence of effects there, because health education we knew wasn't enough, but we learned that from qualitative research. And the story I'm trying to tell here is that you needed multiple data sources and different types of evidence to understand the fuller story around hysterectomy. So between an epidemiologic trial, so a randomized trial, administrative data, qualitative research, in-depth qualitative research with both women and providers in Gujarat, and of course the incidence study. So what we walked away with there was realizing that the hysterectomy story in insurance was quite complicated, because it actually wasn't about insurance. You saw uninsured women having hysterectomies at the same rates. So fast forward a couple of years with the advent of RSBY, and many of you may have read, I guess around 2012 or 13, there were a lot of media reports about RSBY inducing unnecessary hysterectomies. It went to the point of the Supreme Court. There was a PIL, and 3 states actually, Chhattisgarh, Rajasthan, and Bihar, they were directed to respond, and the RSBY introduced extra checks. However, we still didn't have the data. I mean, this was really based on not anecdotal, that's wrong, but on kind of facility-based monitoring data, which wasn't giving you the population-based story. Now, I'm probably biased as an epidemiologist, but without the population-based story, it's very difficult to draw conclusions from only facility-based information, particularly on a health condition. So at that point in 2013, and I think this is really a story of partnerships, many of us came together, researchers, women's organizations, many representatives of government and civil society came together and said, well, what do we do about this issue? And it was important to hear from the multiple stakeholders, including RSBY. And we at that point realized we just didn't have the data to answer the question of whether insurance was inducing hysterectomy. And our argument was, from our experience in Gujarat, was that's the wrong question. The question first had to be, what's driving hysterectomy in the first place? And I think that was a very instructive moment, because the big media question was focusing on insurance and hysterectomy, but the actual deeper public health question was, what is driving this? Because it is odd, you don't see these patterns anywhere else in the world. So we said, well, we don't have population-based data, and at that point requested the inclusion of hysterectomy into the National Family Health Survey, the NFHS. Now, those data were made available to us last year, and the analysis will be out in the next couple of months. But basically what we found was there were 4 states really where we saw higher rates or prevalence of hysterectomy: Gujarat, Bihar, Telangana, and Andhra Pradesh, but all for very different reasons. And again, the NFHS was quite limited because there's only women from 15 to 49. So you don't, again, get the population-based story. So today, I think where that leaves us in terms of policy, evidence, and monitoring data, and trying to kind of put together the pieces, that question of whether insurance induces hysterectomy still eludes us, because we don't have that type of evidence. But what we do have today is population-based data from the NFHS with PMJY, and now analyzing those claims. As we're doing that, we realize this is actually a story about gynecologic morbidity, and this is a story about women's health. So bringing us back to the policy agenda, what one condition within health insurance and the health sector has brought us to is realizing that the policy push and the policy directive needs to be around gynecologic morbidity. And I'll just wrap up in a second. So we just had another similar consultation a few months back, again with representatives of FOGSI, the Federation of Obstetricians and Gynecologists of India, again researchers, activists, and representatives from government, to say, well, what is the next step? Because we have this scheme. But we still see these kind of prevalence of hysterectomy that's very high, again, at a young age. And we know it'll render women vulnerable to NCDs later in life. And the answer has been two. One is to push for much more medical management of gynecologic morbidity within the health system. So to take it out of the question of that procedure at the end, but to look at treating conditions before they reach that stage. And also much closer monitoring of both population-based data and the insurance claims data. And that's really our story of, multiple forms of data, and I think the power of partnerships. And none of this was done by other researchers or policymakers alone.
Great.
Thank you.
Thank you. Thank you so much, Sapna. I think this was, again, you did shift gears, but I think what you brought to the table was, again, a very, very important question that we often forget, is about data, again, not only just serving the role of letting us know whether we are doing the right things, whether things are on track, but also asking some questions which are really fundamental to the things we observe. So we might be observing this thing which is puzzling, why is this happening? But without understanding the sort of the roots of the problem, we would never be able to sort of make or come up with any interventions that can really address that. And the fact that we are still grappling with that, given that the fact that we have PMJY now, and it's going to be, insurance is going to be the thing, whether there are people who are for or against it, that is going to be a key instrument to look at how India really tries to improve its healthcare delivery. This is something that is extremely important, but it's also good to know that all of this did lead to having us collect good data, to that NFHS did include this as a part of that survey, and the fact that we do need to have this outcome level data as well as some of these other more intermediary data. Okay, thank you so much. Now over to Jorge.
Thanks. First of all, thanks for the invitation. It's a privilege and an honor to be in such distinguished panel. I'm going to move away from the discussion of impact. I want to focus on sort of a much more basic form of evidence, or two forms of evidence that are important both for design as well as for monitoring implementation. And these are just some few observations trying to reflect on my own experience as a government official in Mexico, and what I've seen working with government officials for the last 4 years here in India. Probably some of you will know Mexico at some point the government of Mexico was a very active and intensive user of different forms of evidence. A lot of the impact evaluation movement was fostered by certain programs like Oportunidades or Seguro Popular, which made large data sets available to researchers, and by the government itself commissioning impact evaluations at scale. And so that was the sort of the environment that I grew up as a policymaker in. And so when I came, people sometimes ask me, how could India move in that direction? And first, the question surprised me, because as a student of economics, I remember reading Angus Deaton saying, where Mahalanobis goes, the world follows, and India invented household surveys, among other things. And so my first reaction was, what do you mean? How can India go in the direction of Mexico? I thought it was much more like Mexico trying to catch up where India is. And then the second big surprise, so even before talking about impact and establishing causal relationships or answering difficult questions like, does insurance induce hysterectomy, and a basic use of evidence would entail being able to establish a chain between inputs and outcomes, right? And for that, you need basically two things. You need outcome data, right? And you need good administrative data that allows you to track inputs to outputs to intermediate or different levels to the final outcome that you find. And so the first thing that surprised me when I came to India was how sparse outcome data was. I just couldn't understand that between one round and another of NFHS, there could be 10 years. And now we're a little complacent because NFHS 4 finally came out, and we feel there's recent data on a number of outcomes like stunting and others. And then you remember NFHS data is from 2015-16, right? It's already old, even though it's, it's like researchers are like, kids with a new toy. And so the first point in moving towards better use of evidence for policy making is outcome data needs to be a lot more timely, a lot more reliable, and go deeper. You have some excellent data sets. You have people doing panels, but they only cover one state, or they cover 3 states, or 3 rounds were done, and then funding ran out. So you have this great India Human Development Survey, for example, but where that went is unclear. And so I think using Sapna's terms, the evidence landscape, right? An evidence landscape that leads to, I wouldn't say evidence-driven policymaking, because I think that's a little too ambitious. Politics drives policy, yes. And that's the way it is, and probably the way it should be. But at least evidence-informed policymaking is fixing somehow this issue of outcome data being so few and far between, and I mean, things that work in one country may not necessarily work in another country. But the reason Mexico does income and expenditure surveys every 2 years and is able to calculate poverty rates and so on is because there's an independent, autonomous statistical institute that is in charge of, from the census to quarterly employment data and everything in between. And so there's no meddling. There's no, let's not do an NFHS this round. Let's wait another 5 years. But I think India seriously needs to think about its statistical system and strengthen the ability to produce outcome data. And the other, and I see I have 1 minute left, is administrative data. You alluded to it about HMIS. Colleagues of mine did some analysis of our RSBY claims data and found that the quality was left wanting. And I think that's another key agenda in India. Administrative data is a very poor quality, save exceptions. But I think 3 reasons, and with this I wrap up and we can further discuss during the discussion time. But one is we have governments at the center and state and district levels that are very input driven, and partly because outcome data is so sparse, we rely on input planning and monitoring, right? And here lakhs and crores is very important for any foreigner to understand, because it's so many lakh toilets and so many crore houses, and that's what really drives monitoring. Second is a lot of data is collected under what I think about as purposeless fragmentation, right? If you go to a district hospital, I'm not going to name the name of the state where I've been working in, just the exercise of trying to understand how many people were admitted, discharged, and died in this district hospital in a month is a gargantuan task, right? Each ward has a different registry. The maternity ward keeps a registry because they have to report to NHM. The other ward keeps a registry because they have to report to some other vertical program. So first, people don't know why they're collecting data, so it's purposeless. It's just to meet a requirement. And second, this vertical fragmentation leads to, as a unit of a hospital, it's impossible to know anything, right? And third is there's no feedback, right? So people in charge of collecting this data, whether it's the ASHA or the nurse or the medical officer in a district hospital, very quickly learn that they can feel anything in there. And nobody ever comes, to ask where this number came from, or to say, hey, based on this data you've been collecting, here's how you're doing, right? So I think unless we address these three issues, and this goes for health, but it applies to education as well and other fields. Technology itself and enlightened civil servants by themselves are not going to produce a massive quality improvement in administrative data, which is needed if we're really going to move to evidence-based, especially monitoring of implementation of policies and programs. Sorry, I know I took a couple of minutes.
Great, thank you so much. I think for me, at least, there's a lot of food for thought. I'm already thinking about so many questions that I need to go back and look into. But again, thank you. I really have to say it very sincerely. I think this was a really, really engaging panel discussion.